Okay, so last time we were talking about pupillary control, right? We looked at how afferents are all from your optic nerve, cranial nerve 2, receives light, right? Sends it to both Edinger-Westphal nuclei bilaterally. You can see those in green over here. And they also work with your pretectal nuclei, right? The pretectal nuclei is the one that sends it to both Edinger-Westphals. So that's why you see this weird interconnection over here with all four of them being connected to each other. And then you have efferents, right, that are related to the Edinger-Westphal nucleus, because you see the ciliary ganglion here, and then coming back here to your sphincter pupillae, right? This is the stuff that's all going to help you with your constriction, right, to the light that you're being shown in your eye. Now, if you have issues to your pupillary light reflex, oftentimes it's going to be because your optic nerve is pretty much no longer good, right? So you're not actually receiving the light. But if you have issues with efferents, right, then that's a whole different presentation. And one of the things we saw here was the Marcus Gum pupil. We talked about how in this one, right, when you shine light in one eye, both of them constrict, but as soon as you move the light over to the other eye where the optic nerve is kind of damaged, not completely demyelinated, just kind of damaged, that it actually causes both eyes to dilate, right? And that's that's one of your relative afferent pupillary defects. It's called Marcus Gum pupil, and this one is just something that you see randomly occurring, often due to severe retinal disease, right? So you can have any kind of lesion in the optic nerve between the retina and the optic chiasm, as you see here. Another thing that you can have is something called the Argyll-Robertson pupil. That one is the one that's related to neurosyphilis, right? So in this case scenario, as you can see in the picture here, when you shine light into the eyes, neither of them constrict, right? So you can tell that the pupils are pretty wide dilated. Neither of them constrict, but then when you tell them to accommodate, which means to kind of like focus on something very close to them, that you can tell they constricted, right? So this is often referred to as your prostitute's pupil, right? Because the whole concept is that they accommodate, but they do not react, right? And the whole concept of prostitute's pupil also falls in line with the fact that this is related to unsafe sex, because syphilis is an STI. So here I tell you that it's possibly due to bilateral damage to the pretectal nuclei in the midbrain. This is a type of light-near dissociation. Another cause of light-near dissociation is Paris-Naud syndrome, something we talked about earlier in neurology. This is also called your dorsal midbrain syndrome, which has a vertical gaze palsy with pupils that accommodate but do not react, very similar to Argyll-Robertson pupils, and often related to pinealomas, multiple sclerosis, and brainstem infarcts. Okay, so the differential between the two things, Argyll-Robertson versus Paris-Naud syndrome, would be the vertical gaze palsy. There's one last thing I wanted to add in, just in case they ask you something silly about that on an NBME. There's something called Adie's pupil. Adie's or Adie's pupil, also called Holmes-Adie syndrome, is a neurological syndrome with tonically dilated pupils that react slowly to light, but show a more definite response to accommodation, just like Argyll-Robertson pupils again. However, Adie's pupil will, react to light, but it's just going to take a very long time. Often seen in females with absent knee or ankle jerk reflexes and impaired sweating, possibly due to infection-related inflammation of the ciliary ganglion in the posterior orbit. All right. So that's basically some extra notes I wanted to add in, just in case you see these differentials related to pupillary stuff. So when you have anything like this, always use this question. We did this question in the last video right before this, where you kind of, figure out what the issue is. First pick an eye, figure out what the issue is. Is it afferent? Then it's something related to cranial nerve 2. Or is it efferent? Then it's related to cranial nerve 3, and you're not constricting correctly. So those are very good ways to kind of pick out where the problem might be. Now on the next page, we look at Horner syndrome. Right, so Horner syndrome here is a sympathetic denervation of the face. So you get ptosis, anhidrosis, and meiosis, right? Pupil constriction, sympathetic denervation. So basically, you lose the sympathetic activity of being able to do dilation of your pupils, right? Because dilation of your pupils, remember, mydriasis is sympathetic. You have to let a lot of light in so you can see what you're trying to fight or run away from, etc. Right? Sympathetic fight or flight activity kind of stuff. So right here we're looking at the entire sympathetic stuff that we talked about with mydriasis. This entire first, second, and third neuron stuff. Right, all of this is basically being shown on that diagram. Right, so you have your first neuron from the hypothalamus to the ciliospinal center of Budge at C8 to T2. You have your second neuron that exits at T1 and goes to the superior cervical ganglion, traveling along the cervical sympathetic chain near the lung apex and subclavian vessels. And then the third neuron comes back up. That one is a plexus along the internal carotid through the cavernous sinus and enters the orbit as your long ciliary nerve to the pupillary dilator muscles. Sympathetic fibers also innervate smooth muscles of the eyelids, like the minor retractors, and the sweat glands of the forehead and face. And these fibers of the third neuron, they're actually pretty interesting because their anatomy is not the same. So now we can see those neurons. So you have your first neuron right here coming from the hypothalamus down here, synapsing in the lateral horn, right? So this is your C8 to T1 area. And then it comes out at T1, and now you have your second neuron at T1, right, going up here to the superior cervical ganglion. Okay, from your superior cervical ganglion, now it works with your carotids. But note that there's one thing that goes to your external carotid artery, and that's your sweat glands of the face, right? That innervation, the sympathetic innervation of the sweat glands of your face, is through the external carotid artery. The internal carotid artery carries your long ciliary nerve, which causes pupillary dilation, and it carries your innervation, the sympathetic innervation for the sweat glands of the forehead. All right, so very different innervation in that manner. And note also that this pupillary dilator thing, right, the third neuron, it's actually using your ophthalmic division of trigeminal nerve, right? So it's using V1. This is V1. Very important to remember that, okay? Because you don't want to not remember that, because answers are going to have like your trigeminal nerve as an answer choice, and you need to understand that this sympathetic stuff of your dilation of your eyes, mydriasis, actually requires trigeminal nerve function, right? So they didn't quite put that here, right? So totally worth adding that the third neurons, what was it? Long ciliary nerve actually uses V1, the ophthalmic division of the trigeminal. Alright, so that's something that you definitely want to keep in mind, because they mention nerves for everything else, right? So your meiosis is cranial nerve 3, which is efferent. Your afferent of actually seeing light is cranial nerve 2. And mydriasis, which uses the long ciliary nerves, actually works with V1. Okay, so if V1 was not there, that would not actually reach your pupillary dilator. Alright, also this other guy that went to the sweat gland of the forehead also has a little branch right here that goes to the smooth muscles of the eyelid. Right, so when all of this stops working, that's Horner syndrome. Right, all of this is not working anymore. Then you end up getting ptosis, which is a slight drooping of the eyelid because of the superior tarsal muscle. Right, so that's the one that won't be working anymore. So you're going to have slight drooping of your upper eyelid. Anhidrosis, because you're no longer going to be innervating the sweat glands of the forehead or the face. Okay, so you get absence of sweating and flushing of affected side of face. So facial flushing will be there too. And meiosis, right, pupillary constriction, because you can no longer cause pupillary dilation associated with lesions along anywhere, you know, where this black line is going. So you can cause a lesion of the first neuron. So your first neuron, you can see, comes from your hypothalamus, goes along the brainstem, comes down, synapses in the lateral horn. So injury anywhere along that. So pontine hemorrhage, lateral medullary syndrome, spinal cord lesion above T1, like a Brown-Séquard syndrome thing, or late-stage syringomyelia, which would cause a syrinx to compress over here. The second neuron, which is from here to here, coming up and synapsing with the superior cervical ganglion, that can have a stellar ganglion compression by a Pancoast tumor. Right? So a Pancoast tumor meaning something that's up here. the top of your lung, the apex of your lung. And then the third neuron can actually have denervation if you have a carotid dissection, possibly due to really bad hypertension or something, and that would be painful. Okay, so now here we have a question from AMBOSS, and this is something that I really like AMBOSS for. They do this thing where this is the x-ray that you got in the question, and then when you answer the question, the explanation kind of highlights nicely for you all the things you were supposed to be able to visualize, right, to be able to answer the question correctly. So the question's at the top. It says, a 62-year-old man comes to the physician because of a 5-month history of fatigue, progressive shortness of breath, and non-productive cough. He has also noticed that his handwriting has become less neat. He has smoked 1 pack of cigarettes daily for 35 years. He appears pale. Physical examination shows weakness and atrophy of the muscles of the right hand. An x-ray of the chest is shown below with overlay explanation as well. So I put both things there, but the x-ray they show is the one up here. Which of the following is the most likely additional finding in this patient? And the answer was anisocoria, which actually caught a lot of people off guard, right? What is anisocoria? That's literally just ipsilateral miosis. That's why I put that here, right? Anisocoria, because this doesn't have to happen bilaterally, right? It's really important to understand that. This entire PAM stuff doesn't have to be bilateral. So his fatigue, progressive shortness of breath, non-productive cough, smoking history, and the chest x-ray, where you have this opacity of the right superior sulcus, raise a concern for a pancreas tumor or lung cancer. Okay, and that's what they highlighted in red right here. And if you have a pancreas tumor, that's actually going to lead to Horner syndrome, which is what he's presenting with. Okay, so he has symptoms of Horner syndrome as well. And that's something you want to be ready for, right? So one of the main reasons I actually kept this question here, well, two reasons, because I like the way they did this x-ray thing here, so I wanted to share that, and then the terminology of anisocoria. All right, so vocabulary is a big deal here, and you want to make sure you get that right. I also wrote here, remember, ipsilateral Horner syndrome is seen in both pica and ICA strokes, right? And we looked at the strokes already in neuropathology earlier. So make sure, if you forgot either of them, make sure you go back to them and revise the main ways of actually catching someone or identifying someone who might have had a pica or ICA stroke. The latter half of this page talks about ocular motility, something you should be really good at by now. And the chemical formula of LR6SO4 has always been really helpful to remind you that the lateral rectus, which helps you look laterally, is innervated by cranial nerve 6, and the superior oblique, right, which is right here and helps you look towards your nose, like literally in and down, is innervated by cranial nerve 4. All the other guys are innervated by your cranial nerve 3, right? It innervates the rest. Do not think that this stands for innervates all your recti. That's not what it means, because your inferior oblique is also innervated by cranial nerve 3. So the R just stands for rest, not rectuses. So if you look at this image, you kind of get it. You get to appreciate how the muscles kind of look. All the muscles make just enough sense. Like the lateral rectus makes sense. Your superior rectus makes sense. Your inferior rectus makes sense. Like, it's pretty easy to understand them. The ones that are different or unique are your obliques. All right, so you have your inferior oblique, which you can see, it's kind of like attached to this end over here, and it goes, I guess, horizontally under the eye, right? It's not like the other muscles that are going towards the back. This is actually just here to rotate the eye, right? And at the top, you can see your superior oblique as well, right? So they're both muscles. They're both muscles that kind of attach to the outer portion and are connected towards the nasal portion, right? So from left to right in a sense. And your obliques all help you look more medially. Always remember that. Your inferior oblique helps you look medially and up, and your superior oblique helps you look medially and down, which is kind of backwards based off of the way they're named. So don't get confused by that. Your inferior oblique is helping you look up, and the superior oblique, it turns your eye in such a way that you start looking down. So the name of the muscle is actually based off of the location of the muscle, not the way it's making you look. Okay, so that is actually true about all the muscles. So your superior rectus, yeah, I get that it helps you look up, but the superior rectus is actually named the superior rectus because it's at the top. All right, not just because it helps you look up. So very important to understand that. And just based off of that, you can understand that the superior oblique is only called that because it's at the top. Right? It uses this hinge over here. Right? It goes through the hinge, attaches like that, and its job is to help you rotate the eye and look down and in. Okay, so obliques go opposite. The left SO and IO tested with patient looking right. IO tested looking up. Okay, so the inferior oblique is tested by looking up, and to test the oblique of either eye, you have to make the other eye look the other way. Right, so the left SO, for example, right here you have your right and left eye. So if I want to test somebody's left superior oblique, right, so the left eye superior oblique. So basically I'm trying to test this function, right? So if I'm trying to test this function that I highlighted here, the only way I can do that is I have to make the patient look to the right first, okay? And that makes sense because, you know, looking to the right means looking this way, and then I'm going to tell them to look down, right? So then they're going to look down, and that combines to give you this motion. So you get what they're trying to talk about. Don't get confused by it, right? Same thing here. If I want to test my right eye's inferior oblique, well, first I have to tell the patient to look to the left, and then I'll tell them to look up, so you can get this combination. Alright, so that's basically all that's happening there. Nothing too confusing. More so during, I guess, CS is where you're going to have like patients where you might have to actually test the function of each eye by asking them to look in certain directions, and you have to vocalize which function and which muscle you're testing. So that's kind of where this will be a lot more significant. Down here we have questions related to something that's on the next page, so I'm going to come back to this after we cover the palsies here. Right, so the first palsy we have is your cranial nerve 3 palsy. So right here, cranial nerve 3 has both a motor or central and a parasympathetic peripheral component. Common causes include ischemia, where the pupil sparing motor fibers affected more than parasympathetic fibers. Right, so ischemia is going to cause issues. Ischemia is going to cause issues more so outside, right? Uncal herniation, which can often lead to a coma as well. Posterior communicating artery aneurysm, which will have a sudden onset headache with it, as we've discussed. This has already been discussed earlier in pathology as well. Any cavernous sinus thrombosis can cause proptosis and involve cranial nerves 4, V1, V2, and 6. Or a midbrain stroke, where you can have contralateral hemiplegia. Overall, though, there's many reasons any of this can occur. You're not going to get tested on all of them, but there are some that are more high yield than the other. But before we look at causes and presentations and questions, let's just make sure we actually understood what's happening. So you can see over here, this is your cranial nerve 3. The outer shaded region is the parasympathetic peripheral stuff. Right? So that's what they're talking about, peripheral parasympathetic. Really easy to remember that, right? Peripheral parasympathetic. They both start with a P. That's your shaded stuff. The white central stuff is the central motor. Okay, central motor. So the central stuff is your motor output to your extraocular muscles, affected primarily by vascular disease such as diabetes, where glucose becomes sorbitol due to decreased diffusion of oxygen and nutrients due to the interior fibers from compromised vasculature that resides on the outside of nerves. So what are they talking about? Basically what's happening is, let's say you have this is red, so let's say we have some blood vessels out here, right? All these blood vessels are supposed to bring nutrients to the outer portion and the inner portion and then the center, right? So that's 3 different layers or 3 different levels of depth. If you have any kind of diabetic issues where these blood vessels are kind of not working too well now, then you're probably only going to supply blood to the outer layer, right? Whereas the inner layer will no longer be getting blood, and that's going to cause vascular disease, right? Oh, that is the vascular disease that's going to cause your visual difficulty. Okay, so you want to be really careful with what's being read in a question. Make sure you really understand what the true issue is each time. All right, really significant. That's just the central motor stuff, though. All right, so we're talking about anyone with diabetes and vascular disease because of diabetes. If they're not able to supply the central region, then they're not going to have good motor output. Then you have how do you injure the parasympathetic outer area? Because the vascular disease will still be supplying parasympathetic outer area. So this fibers on the periphery are first affected by compression, either because of some kind of aneurysm or some kind of uncal herniation, and both of them have similar signs, but there's one thing that differentiates them. If you injure the motor central stuff, right, then you're going to have ptosis and a down and out gaze. But if you injure the parasympathetic stuff outside, you're also going to have a blown pupil. Okay, blown pupil. You're still going to have a down and out gaze. Anytime you injure cranial nerve 3, you're always going to have a down and out gaze. But the main thing is your blown pupil, right? These people with the damage to the parasympathetic stuff, they have diminished or absent pupillary light reflex, which means they cannot constrict their eye that well, right? Not because they don't see the light. It's not an afferent injury. It's because they can't do the efferent aspect of actually constricting the pupil, right? Constricting your pupil is a parasympathetic thing. So that's going to be the main difference between the two. And that's what we have visuals of up here, okay? So you can see two different variations, right? You can have either aneurysmal compression of your oculomotor nerve. So this is your possibly your posterior communicating artery, right? PCOM, and you have an aneurysm here compressing the parasympathetic outer, right, peripheral parasympathetic layer outside, right? So that compression now you can see causes a dilated pupil, right? Early dilated pupil and loss of accommodation, late ptosis and ophthalmoplegia, and they're also going to have the same down and out eye, right? So that's something that you're seeing there. Here, if you have central infarction, possibly because you have diabetic ophthalmoplegia or vascular disease that did not allow you to bring nutrients to the central motor area, then these people lose their motor ability, so they immediately have a down and out pupil, but they have a normal sized reactive pupil, right? They are able to cause meiosis of the pupil because the parasympathetic outer lining, right, sparing of superficial parasympathetics. That parasympathetic outer lining is working fine, right? But here, compression of the superficial parasympathetics led to mydriasis because you were unable to do meiosis now, right? So the opposition wins. And here's some questions looking at this kind of scenario. So they're both from UWorld. The first one says, a 59-year-old man comes to the emergency department with diplopia that started several hours ago. His past medical history is significant for long-standing diabetes with poor glycemic control, right knee osteoarthritis, and peptic ulcer disease. Physical exam shows right-sided ptosis with the right pupil in the inferolateral position. Pupils are equal in size and reactive to light bilaterally, which means that cranial nerve 2 is working fine, right? Because he's able to see the light. So they're equal in size, and they are reactive to light, which means they're constricting. So that means that the parasympathetic peripheral area is working fine. This patient's condition is most likely due to what etiology? But we just told everything that's fine, so the one thing that must not be fine is the nerve ischemia, possibly due to diabetic ophthalmoplegia. Right? This neuropathy is a common complication of diabetes mellitus. The clinical features of diabetic neuropathy vary considerably depending on the pattern of nerve involvement, which can be broadly divided into polyneuropathy, mononeuropathy, and autonomic neuropathy. Mononeuropathies are further divided into cranial and peripheral types. All ocular motor nerves 3, 4, and 6 can be affected in diabetes, but unilateral cranial nerve 3 involvement is the most common. Diabetic cranial nerve 3 mononeuropathy classically presents with acute onset diplopia, double vision. On exam, the affected eye assumes a down and out position due to the unopposed pull by the superior oblique and lateral rectus muscles. Paralysis of the levator pulpebrae leads to ptosis. Diabetic mononeuropathy is caused by ischemic nerve damage, which predominantly involves the core of the cranial nerve 3 with relative sparing of the peripheral parasympathetic part. The somatic component of cranial nerve 3 that innervates the extraocular muscles is located centrally, but the autonomic part responsible for pupillary constriction and accommodation is located in the peripheral aspect of the nerve. Therefore, pupillary size and reactivity is normal in our patient. Cranial nerve 3 neuropathy can also occur due to nerve compression. Causes include transtentorial or uncal herniations, neoplasms, and aneurysms of the posterior cerebral and posterior communicating arteries. In contrast to cranial nerve 3 diabetic mononeuropathy, pupillary dysfunction is often an early manifestation of external nerve compression due to injury of the peripherally located parasympathetic fiber. Right? So whether or not it reacts to light was the main differentiating factor between aneurysmal compression of cranial nerve 3 or diabetic ophthalmoplegia of cranial nerve 3. And our patient in the top question had diabetic ophthalmoplegia. Here's another one. This one says a 55-year-old right-handed man comes to the emergency department. Comes to the emergency department due to recent onset of severe throbbing right-sided orbitofrontal headache and vision loss. His medical problems include poorly controlled hypertension and chronic tobacco use. Neurologic exam shows that he is awake, alert, oriented, and follows both simple and complex commands. Cranial nerve testing shows intact visual acuity bilaterally. Visual fields and optic fundi are normal. There is anisocoria with the right pupil dilated and non-reactive to both light and accommodation. There is also evidence of both vertical and horizontal binocular diplopia. The right eye is down and out, which is a giveaway for cranial nerve 3, with ipsilateral ptosis. The rest of the exam is normal. Based on his neurologic deficits, CT angiography of the head is most likely to reveal an aneurysm from what location. So they gave you a bunch of shit in this question that you didn't need as soon as you saw that the right eye is down and out with ipsilateral ptosis. That's the diagnostic sentence right there. You immediately know cranial nerve 3 palsy right there. What's causing it? Well, they also told you that his eyes are not exactly reacting to light, right? So dilated, and at that point you know it's going to be some kind of compression. So that's when you pick any one of those compressions of arteries that would be here. And the answer choice for this question was it'll be an aneurysm somewhere at the junction of the right posterior communicating artery with the internal carotid artery, right? So PCOM. I mean, they didn't want to just put PCOM. Key giveaway was his dilated and non-reactive eye compared to the previous question, right? So two different variations. Both of these questions basically show you the different things in these two things, okay? So two different presentations. Really make sure you understand the difference between the presentations, because it's pretty easy. The differences are really vast. I mean, the biggest difference is the fact that your eye is dilated. If you lose the peripheral parasympathetic aspect of things, you will have a dilated pupil, and that's when you know it's some kind of compression, either because of an uncal herniation or an aneurysm. Alright, so that's your cranial nerve 3 palsy. There's one more question right here. So this one's from Amboss. This one says, a 65-year-old man comes to the physician because of double vision that began this morning. He has hypertension and type 2 diabetes. He has smoked 2 packs of cigarettes daily for 40 years. His current medications include lisinopril, metformin, and insulin. Physical exam shows the right eye is abducted and depressed with slight intorsion, which is a really, really complicated way to say down and out. Visual acuity is fine. Extraocular movements of the left eye are normal. Serum studies show a very high A1C of 11.5%. Which of the following additional findings is most likely in this patient? And then as soon as you see upper eyelid droop on the right eye, you pick it, right? Because you remember from your Horner syndrome image that your upper eyelid is the one that has your innervation from the long ciliary nerve stuff, right? Not exactly the long ciliary nerve, but the third neuron, basically. The third neuron that goes from your superior cervical ganglion along with your internal carotid artery, okay? So they go on to explain here that ptosis occurs in patients with oculomotor nerve palsy because the levator palpebrae superioris is innervated by the oculomotor nerve, whereas patients with oculomotor nerve palsy due to compression usually show dilated pupils. Those with diabetic motoneuropathy normally do not have pupillary involvement because the microangiopathy typically involves the vasonervosum within the oculomotor nerve, the blood supply of the nerve itself, while the peeled blood vessels which supply the superficial parasympathetic fibers are usually spared. Right, so just some extra stuff there. But again, this is a third question about the same thing, cranial nerve 3 damage. Very common topic. It will definitely be on your step 1. You might even see it more than once on your step 1, so totally worth knowing. The other two guys, you'll probably see them each once on your step 1, but it'll definitely be there. First one, cranial nerve 4 damage. So remember, your obliques are only tested by looking the opposite way. So if you're testing your right superior oblique, you have to tell the patient to look to the left. So pupil is higher in the affected eye, okay? So in the affected eye, your pupil is higher. characteristic head tilt to contralateral unaffected side to compensate for lack of intorsion in the affected eye. Can't see the floor with cranial nerve 4 damage, right? So you see the rhyme there. So in this question here, you can tell the right eye is a little higher than her left is, right? This should have been lower. So this patient in this question has, or in this image, I mean, has a cranial nerve 4 damage in the right eye, right? And how would you test that? You would tell her to look to the left as she's doing in this image, right? So she's looking to the left right now, and you can see that this eye, right, is too far up. Why is it too far up? Because her cranial nerve 4 is not working. And remember, your cranial nerve 4, right, is SO4, right? SO4. So your cranial nerve 4 is for your superior oblique, and your superior oblique's job was to pull it down. But since your superior oblique is not working, you're unable to pull it down, so it's just looking up. And that's it, okay? So really straightforward stuff there, nothing crazy. The head tilt is always going to be in the question. Basically, the concept of the head tilt is to fix the axes, as you can see from this U-rolled image. Right, so see, again, in this image, this patient's right eye trochlear nerve is not working well. So it's a little higher than the left eye. And you can see how the axis is kind of messed up. So you have to do the head tilt, right? Characteristic head tilt to the contralateral side. So since this patient's right trochlear nerve is not working, they tilt their head down on the left side, and then immediately you can see the two axes now match. The reason they match is because this patient just fixed this one. She fixed this one to make it nice and straight. The left eye, all the muscles are working fine, so she's just, looking correctly with her left eye to match the axes. So to fix the right eye's axis, she actually had to tilt her head. But her left eye already has the correct axis. She just has to look a different way, okay? And this is your superior oblique as we saw earlier, right? So you see a trochlear nerve. It goes onto this hinge. There is a hinge for this muscle. Always remember that. If they mention a hinge for one of the muscles, the only ones that have it are your superior and inferior oblique. Mainly, a hinge will only be mentioned for your superior oblique. The inferior oblique often doesn't really have a hinge. I've seen drawings with both things for it. But I know the superior oblique always gets drawn with this kind of hinge. As you can see, it's going into it, then it comes out like that. Okay. So this one is not going to be working, and they will not be able to do this looking down like that thing. Okay, looking down towards your nose, I guess. The other palsy you have is your cranial nerve 6, right? LR6. So that's your lateral rectus. It's supposed to help you look laterally. So you could tell already in this image that this patient's right LR6 must not be working because she can't look that way. Right? Clearly she's been told to look towards the right, and this eye is not looking. Right? But if she was to look towards the left, both of these eyes would look. Keep in mind that discussing which way your eyes are looking is very weird. If you tell a person to look towards the right, then you can tell, as soon as I tell this patient to look to the right, then her right eye is going to be looking laterally, but her left eye is looking medially. And these two are different muscles, right? This is your medial rectus, which is one of your cranial nerve 3 things. This one here is your lateral rectus, which is a cranial nerve 6 thing. Right, so really important to remember that the muscles that you use, even though you're looking in the same direction, the muscles that you use are different. So don't get too confused by stuff like that. It's just, take it slow and easy. Make sure you're very organized. So here they tell you, cranial nerve 6, affected eye unable to abduct and is displaced medially in the primary position, right? And abduction, adduction, all these things, remember, abduction is like being abducted by aliens, so they are unable to kind of look like laterally. That's really all that's happening there. Adduction is adding things together, so you're making both eyes look medially. And this patient can adduct just fine, but she cannot abduct. And here's a question from UROD for cranial nerve 6 damage. So a 53-year-old man comes to the office due to double vision. The patient lives in a 2-story house and has had difficulty. So I know this is a cranial nerve 4 question. Has had difficulty walking downstairs because he sees duplicates of every step and doesn't know which ones are real. Right? And that's pretty much iconic of, or classic of what they expect or what they want you to expect cranial nerve 4 questions to be about. People going down the stairs will not be able to see correctly because they can't look down. Right? They cannot look down that well. Even though their inferior rectus is working fine, their superior oblique is losing to the inferior oblique. Right? The superior oblique is not working, so the inferior oblique is the one that's actually making her look in that direction. This is an inferior oblique function. Right? Inferior oblique is cranial nerve 3, so this patient is unable to look down correctly. So let's see, where was I? Which ones are real? He does not have significant problems walking up the stairs. The patient is also frustrated because he has trouble reading certain things, such as the morning newspaper and work-related documents, which are all below you. They're down here. He has had no eye trauma, headache, focal weakness, or numbness. The patient has a history of hypertension and diabetes 2 and exercises regularly while avoiding alcohol, tobacco, and drugs. A lesion of which nerve is most likely causing his symptoms? And this is classic trochlear nerve damage, can't go down the stairs correctly. Right? Another variation of this question would be someone who has to tilt their head to be able to look at things below their nose correctly, right? And that would also be a sign of trochlear nerve. In fact, trochlear nerve is very unique. The only thing that you're ever going to have for your other guy, the lateral rectus, is just not being able to abduct your eye. That's it. You're just not able to look laterally. Right? There's no head tilting. There's no confusing story, anything. Cranial nerve 6 is really easy to identify. But because of that, cranial nerve 4 is also very easy to identify. They're going to have difficulty just looking below their nose because they can't make their pupil go down. Cranial nerve 3 is a very complex one that you'll also pick out very easily because it has its own set of things. Down and out, peripheral parasympathetic compression, right? Or central vascular disease. Either one of those things will have different presentations. Right? So make sure you really grasp that well. Now this image, this is something I found online on Google. This is a really good picture, kind of showing you the optic tracts, but not just the optic tracts, they're also kind of associating it with the correct arteries. Right? So you can see all the arteries that we've been looking at so far, along with the optic tract. Right? So both things together. And what you're supposed to see in this image, I wrote here that this image shows the association of the middle cerebral artery with the two different quadrantinopias. The posterior cerebral artery with the hemianopia with macular sparing. So you can see your posterior cerebral artery is this one right here, right? And when you have infarction of that, you can have your hemianopia with macular sparing and the internal carotid artery with unilateral right nasal hemianopia, right? And that's your internal carotid right here, right? You can see your optic nerve passing by it, and this is your middle cerebral artery going through here, right? Deep branches of the middle cerebral artery all kind of help supply your optic radiations, and these arteries are actually involved in some of the things that are on the next page, which are your visual field defects, right? So basically what this image does is if you look at them side by side, you can kind of see where the defects are, and you can see what the arteries supplying those areas are like. Okay, so that's what this image was useful for. Totally worth looking at. And then when you look at this stuff, this is the stuff that takes a little bit of time. You want to make sure you give it the time it'll need to actually grasp it. Visual field defects, they have 7 here, but there's actually let me see, 1, 2, 3, 4, 5, 6, 7, 8 different ones, right? So really worth knowing. I mean, you can keep a 7. This is another image. This is the one from UWorld that shows 8 of them. But just make sure you catch everything in there. Let me just see which one's missing real quick. Which one are they missing? Oh, they're missing. Let me see. They have the central scotoma. They have the entire blindness of one eye. They have this one here. Right nasal hemianopia. That's the one they're missing. Where you have hemianopia of just one eye. Right, that's the one that's not here. Right, your right nasal hemianopia, the one they're missing in first aid, would be a compression like right there, like that, right? Like image D. We see how in image D they've kind of separated the green and the blue line. Remember earlier we saw the same image in the book. They use red and blue. So the green line is the one that's kind of going from outside and staying outside and using these tracks like that. When you compress only that, then you get this scenario, right nasal hemianopia. Because remember, your outer part right here is looking at your nasal vision. Okay, so that's the only one that the book itself is missing, and you do need to know that one too. So we'll talk about that. But as far as the book, it shows you have your optic nerve, you have your optic chiasm right here, right, and then you have this breakdown in your optic tract, which then further divides into the temporal Mayer loop and the dorsal optic radiation in the parietal lobe. Right, later on they all connect, and this area might not be working well if you have either number 3, which is a left well, they have 3 and 6 both written, but there's 2 ways of this issue happening. If it's just injury of those areas, then you're just going to have case number 3, left homonymous hemianopia. Homonymous meaning that it's all on the same side. But if you have a PCA infarct, then you're going to get case 6, which is the same as case 3, but you have macular sparing. Okay, so that's the main difference between 3 and 6. Now, you can see for cases 4, 5, and 6, arteries are involved, right? So case 4, where you have your left upper quadrantinopia, or case 5, where you have a left lower quadrantinopia, so pie in the sky or pie in the floor, whatever you want to call them. Those are all related to your middle cerebral artery, right? But if you have the pie in the sky, left upper quadrantinopia, that is a right temporal lobe lesion, or right temporal area MCA infarction. If you have a left lower quadrantinopia, like case 5, that's a right parietal lesion. Okay, so you have your temporal lobe and parietal lobe both being involved, and that's because they involve different loops, right? Your temporal lobe is your Mayer loop, your parietal lobe is just the dorsal optic radiation. Right, so if you have an injury of number 4, if you have an injury of your Mayer loop, which is higher in this image at least, then you get the pie in the sky issue, right? You lose the higher quadrant up here. If you have an injury of a dorsal optic radiation, which is lower in this image, then you lose this lower area like that. Okay, and those guys can also be related to MCA. So really important to understand that. That's because of the way this branch of your MCA goes like that. Right, so these are your 2 different radiations. They're being shown together. Central scotoma, which is image 7 here, was something we looked at already. That was mostly age-related macular degeneration. Right, so that's the only time that ends up happening, most commonly. All right, so Mayer loop, lower retina, loops around the inferior horn of the lateral ventricle. Dorsal optic radiation, superior retina, takes shortest path via the internal capsule. And internal capsular strokes were something we did a lot of questions on, where patients presented with motor deficits. Okay, I wrote up here number 8, right? The 8th one that's missing over here is your right nasal hemianopia, occurs due to calcification or aneurysm of the internal carotid artery impinging on the uncrossed lateral retinal fibers. Injury would be right between 1 and 3, which I drew for you guys earlier, something like that. Okay, and affects only the fiber transmitting the nasal vision. So the fiber stays to the right side of the optic nerve and tract. Lesion would be like D in image below, so like that. Okay, that's your D thing right there. 7, the central scotoma. That one I just talked to you guys about, the age-related macular degeneration. That's it for that. Note, when an image hits primary visual cortex, it is upside down and left-right reversed. Now, if you're confused about this part, you should check out some pictures where you'll kind of be looking at an actual object over here, and then you'll see how it arrives back here. Right, so anything we look at, by the time it gets to our actual primary visual cortex, first of all, it's upside down, and it's left-right reversed. It's a very common thing that can pop up on a question, and you can definitely get a very bullshit question where they show you the object you were looking at, and then they'll be like, how was it supposed to look like when it got to the primary visual cortex? So you got to be ready for that. So train yourself for that. Check out some pictures where they show you what it looks like to be looking at something when it's now upside down and left-right reversed. Okay. Last thing on this page is something we've already actually looked at quite a bit before, cavernous sinus, right? Because you can get cavernous sinus thrombosis and cavernous sinus syndrome as a result. Your cavernous sinus looks just like this, right? So it's somewhere like right here, right? So it's a sinus right up here. This is your sphenoid sinus, right? You have your pituitary back here, and this is the area you're kind of visualizing here. You have your third ventricle up here, okay? And in here, you can see there's a couple nerves and arteries. Right in the middle, you have your optic chiasm with cranial nerve 2, okay? This is your pituitary, perfectly sitting inside the sella turcica. In this lower area, this is where all the action occurs. You have your internal carotid artery, right next to which is cranial nerve 6. Okay, so internal carotid and cranial nerve 6 are highly related to each other. Along the wall are all the other guys. So the only one that's not along the wall is cranial nerve 6, and you can rest assured you're going to get a question on that. The others are your cranial nerves V2 and V1, as well as 4 and 3. Okay, so all in all, everything visual definitely goes through this entire cavernous sinus thing. Right? Everything related to vision goes through it. So this is a collection of venous sinuses on either side of the pituitary. Blood from the eye and superficial cortex can cause go to the cavernous sinus, and then it goes to the internal jugular vein. Cranial nerves 3, 4, V1, V2, and 6, plus postganglionic sympathetic pupillary fibers en route to the orbit, all pass through the cavernous sinus. Cavernous portion of internal carotid artery is also here. Right, so you have your internal carotid artery two times. This up here is your anterior cerebral artery. So what can go wrong? If you have cavernous sinus syndrome, this presents with variable ophthalmoplegia depending on which nerve is compressed, decreased corneal sensation, Horner syndrome, and occasional decreased maxillary sensation because of V2. Secondary to pituitary tumor mass effect, carotid cavernous fistula, or a cavernous sinus thrombosis related to infection. Right? All three of which can cause the same issues, but the most common type being the cavernous sinus thrombosis. That's what I've seen the most questions on. The second most common thing that you get questions on are your pituitary tumor mass effect. So let's look at this question right here. This is related to this topic. So I think this one's from Ambos. This one says, a 54-year-old woman comes to the physician because of a one-day history of fever, chills, and double vision. She also has a 2-week history of headache and foul-smelling nasal discharge. Her temperature is super high, 103 F. Examination shows mild swelling around the left eye. Her left eye does not move past the midline on far left gaze, but moves normally when looking to the right. Without treatment, what finding is most likely to occur in this patient? And then you look at all your answer choices and you pick something that's related to vision. Absent corneal reflex is good enough. This patient has signs of acute bacterial sinusitis. She also presents with periorbital edema and abducens nerve palsy, right? Because she can't look laterally. That's what they describe to you. But she can look medially when she's looking the other direction, right? They literally said it. Her left eye does not move past the midline when she's looking to the left, which means she can't look laterally. But it moves normally when she's looking to the right because her left eye would be moving medially. So lateral rectus wasn't working, so it's very clear that this was a cranial nerve 6 injury, which is inside your cavernous area. Then they go on to tell you, which is often the earliest cranial nerve palsy and cavernous sinus thrombosis, a rare but dangerous complication of acute bacterial sinusitis. Cavernous sinus thrombosis can also compress the other cranial nerves that pass through the cavernous sinus, 3, 4, V1, V2. Compression of V1 would lead to loss of corneal reflex in this patient. So basically what the takeaway here is that anything related to any one of these nerves in here could have been a correct answer. Okay, so you got to be ready for that. You got to remember the nerves that are in here along the wall. You got to remember the nerve that's in here right next to your internal carotid, and understand that if you ever have a cavernous sinus thrombosis or pituitary tumor mass effect or anything in here that's causing inflammation or issues, can cause symptoms related to any one of these nerves. At the bottom, I have one more question. This one is, a 48-year-old man comes to the hospital after a day of high-grade fever, progressive headache, and double vision. The patient has been having purulent nasal drainage and frontal headache for the past several days. He has a history of type 2 diabetes. His temperature is 102 F, blood pressure is 110/70, and pulse is 94 per minute. Physical exam shows ptosis, mydriasis, mild proptosis, and loss of corneal reflex of the right eye. Visual acuity is normal in both eyes, but the patient is unable to move the right eye in any direction. There's also decreased sensation in the right upper face. What structure is most likely involved in this patient's presentation? Well, first of all, this patient's presentation is involving many cranial nerves. If he can't move his right eye in any direction, then 3, 4, and 6 all just got messed up. And as soon as you see your answer choices and you see the cavernous sinus there, you just pick it, because all these nerves go through the cavernous sinus. This patient must have an infection because of his high-grade fever, in the question as well. So infection of the medial face, sinuses, or teeth may spread through the valveless facial venous system into the cavernous sinus, resulting in cavernous sinus thrombosis, presenting with all the symptoms of every single nerve in here. Okay, that's why test writers like the cavernous sinus. There's a lot of cranial nerves in here, a lot to test you on. The last topic, and this is actually a pretty confusing one for many people too. The last topic in ophthalmology is your INO, which is directly related to multiple sclerosis every single time. You ever see INO, you just go with multiple sclerosis. That's it. Internuclear ophthalmoplegia. What is this about? So we're seeing the same tracks we've been looking at before, and this image in 2019 does a much better job than the 2018 one and previous versions of first aid. So what are we seeing here? You can see your oculomotor nerve in the midbrain, right? And then when you come to the pons, you can see your PPRF, the paramedian pontine reticular formation. You can also see your abducens nerve, and there really isn't anything in the medulla at this point. So what's wrong here? What's going to go wrong? So if you tell this patient to look to the left, right? Because we're gonna have some kind of vertical gaze issue. We tell the patient to the left, look to the left. What's supposed to happen? When they look to the left, that's done by the right frontal eye field up here. Okay, so that's sending in information to your left stuff right here, right? The left PPRF. Your left PPRF sends information to the abducens nerve, as well as allowing the abducens nerve to tell it to do stuff to both eyes. So look at what's happening. Looking to the left required your left eye's lateral rectus and your right eye's medial rectus. But your abducens nerve, right, abducens nucleus, is responsible for being able to do this, right? You need your abducens nerve because remember the LR6, your lateral rectus, is only functional by the abducens nerve. So your abducens nerve helped you look laterally to look left, but for your right eye to also look left, this connection needed to be there, the green line. And INO is an issue with that green line. Okay, what is this green line over here? This green line is your right medial longitudinal fasciculus, allowing your abducens nucleus to tell your oculomotor nerve to look to the left, right? Because the medial rectus of either eye is oculomotor. Okay, and that's why internuclear ophthalmoplegia is confusing to many people, because it involves two different nerves and two different muscles doing the same exact thing. They're both looking to the left. Okay, so what's going to be the problem? It'll look like this. You're going to tell the patient to look to the left, and if their right MLF is not working, their right eye will not look to the left. It's a very easy way to talk about it. Do not get confused by figuring out right, left, and all of that stuff. This is a directional thing. It's a directional thing. This is, you're naming a problem, right? So problems are named based off of the actual problem, right? This person's right eye, what's the problem in this image? On left gaze, this person's right eye is not looking to the left. So this person has a right MLF lesion. That's it, right? You name a problem based off of where the problem is. So the problem here is on the right side. The right MLF is not working. So for some reason, this person's left abducens nucleus was unable to tell the right oculomotor nerve to look to the left. All right. Make sure you understand that very well. Do not get confused. Now, although this person cannot look to the left for left gaze, right, they can converge just fine, right? So when he wants to look at his nose, both eyes will look medially just fine, because to do that, you did not need the right MLF. Okay, his cranial nerve 3 is working just fine. So if he needs to converge and look towards his nose, he can do that just fine. Okay, and of course the superior oblique is also working, right? So LR, what is it? Your the cranial nerve 4, the trochlear nerve, as well as your cranial nerve 3 are both working just fine. Right. In fact, all three of these guys are working just fine. Even the abducens nerve is working fine, both of them. It's just that this one connection between the abducens nerve to the oculomotor nerve, the green one right here, called the MLF, is not working fine. Right? And once that happens, that's when you know there's an issue. Right? So directional term, right INO, left INO, refers to the eye that is unable to do the job. Right? Cannot adduct. The eye cannot adduct. The eye that needed to look towards the center can't do it. Right? Lesions may be unilateral or bilateral. If it's bilateral, that's classically seen in multiple sclerosis or in a stroke. Right? That's basically all there is to that. Don't overcomplicate it. Just make sure you get the fact that the issue is with this medial longitudinal fasciculus. That's it. Okay, it's unable. Your abducens nerve is unable to tell your oculomotor nerve to coordinate looking left or right together at the same time. But convergence is completely normal. All right. So to top it off, I have 2 questions at the bottom, and they teach you one more thing that now they show you, right? Because this lower image, this lower question has something that this image did not used to show before. So let's take a look. First question on the top: 26-year-old woman is brought to the emergency department due to acute onset diplopia. Anytime you ever read that, acute onset diplopia, young woman, multiple sclerosis. Medical history is significant for episodes of blurry vision involving her right eye that occurred 6 months and 2 years ago. Multiple sclerosis is disseminated in space and time. These episodes were associated with deficits in color vision and pain made worse with eye movement. The patient recovered the majority of her visual acuity after a few months in both cases. On neurologic exam, she has a visual acuity that's just okay. Mild right optic disc atrophy. Oh yeah, the right one is 20/40. Okay. And a relative afferent pupillary defect in the right eye. So the left eye is doing okay, but the right eye not so much. There is slowed and impaired adduction of the left eye with right lateral gaze. So this patient has an issue with the left MLF, which is very much a sign of MS, multiple sclerosis. Convergence testing shows normal adduction in both eyes. This patient's diplopia is most likely caused by what mechanism? Reduced saltatory conduction, demyelination, multiple sclerosis. That's it. She has internuclear ophthalmoplegia, an issue with her left MLF because it's her left eye that does not look to the right. All right. Next question here is: 68-year-old woman comes to the emergency department due to sudden onset double vision. The patient woke up with symptoms and notices that they worsen when looking to the right. She has no headache, weakness, or numbness. The patient has a prolonged history of hypertension, hyperlipidemia, and type 2 diabetes. Her blood pressure is super high, pulse is 86 and regular. Neurologic exam, including visual acuity, is normal with the exception of the ocular findings shown in the image, which describes that the left eye does not adduct on rightward gaze. So that looks like another left MLF lesion. But the leftward gaze works fine and convergence is also fine, right? Left MLF issue. A lesion at which location is most likely causing the observed ocular finding. And the correct answer here was your left dorsal pons. Okay, if we're talking about the left MLF, in this image we're talking about the right MLF, so that's your left dorsal pons right here. Okay, wait, hold on, what's happening here? The left eye does not adduct. Yeah, so your left dorsal pons, because this is the other way around, by the way. In this image, we're talking about a patient with left gaze and your right eye doesn't work. But in our question, right, describes that the left eye does not work on rightward gaze, the other way around. So remember, whichever eye is not working, right, this is a directional term, whichever eye is not working, that's the place where the issue is. So it's your left dorsal pons or your left MLF, whatever you want to call it. The patient has left INO and the MLF is in the dorsal pons. Okay, so really easy stuff. Don't mess it up. This is also a really easy question. This is just something that super straightforward. Patient comes into your office because she noticed that her eyelid has been drooping. Upon further observation, you also realize that her right pupil is smaller than her left one, so it's constricted. It's not dilating. So you're seeing meiosis and ptosis. She probably also has anhidrosis because that sounds a lot like Horner syndrome. Which of the following are you most likely going to find on further testing? And none of these other ones are related to Horner syndrome in any way except for B. A bronchogenic carcinoma, most likely at the apex, compressing the second neuron. And that's it. All right, so that's the end of all things neurology except pharmacology. Neuropharmacology is a very dense chapter. It requires revisiting multiple times. You have your epilepsy drugs, then you have a bunch of different medications for different things, but then they also go into in-depth teaching about anesthetics. Right? They're going to teach you general principles of anesthetics within the pharmacology chapter, and then talk about different anesthetics. And you have to understand how anesthetics work really well. They love testing you on anesthetics. UWorld has so many questions on anesthetics, so I put some of them here too. So we'll do all of that in maybe 2 more videos to finish up neuro and finally move on from neuro. Right? Really big chapters, so make sure you revise things as much as you can. Epilepsy drugs take a while to memorize and really instill into your mind, so I'm going to use whatever memorization techniques I can share with you guys, and we'll continue that from tomorrow on. Thanks a lot for joining.